His standard biopsy came back negative, 12 samples, no cancer detected. His urologist said, "Good news. PSA is likely elevated from benign causes. We will monitor every 6 months." His wife was not satisfied. His PSA had risen from 6.8 to 9.1 over 18 months. His free PSA ratio had dropped from 22% to 14%. Two markers moving in concerning directions simultaneously. She researched detection methods for 3 evenings, found studies on MRI-targeted biopsy, genetic markers, and liquid biopsy technology that her husband's urologist had not mentioned. She asked for a referral to a major academic medical center. The second urologist ordered an MRI before any further biopsy. The MRI identified a suspicious lesion in the anterior zone of the prostate, an area that standard 12-core biopsy consistently undersamples. Targeted biopsy of that specific area found Gleason's 7 prostate cancer. The first biopsy had missed it entirely because it sampled the wrong locations. His wife said afterward, "The first test did not find it. The right sequence of tests did." His urologist at the academic center said, "This is not a rare outcome. Standard random biopsy misses approximately 20 to 30% of clinically significant cancers located in areas the systematic cores do not adequately reach. The detection pathway matters as much as the decision to detect." Today, I am sharing what that detection pathway looks like, how each tool works, what research shows about accuracy, and what every man with elevated PSA over 60 should know before agreeing to any single detection approach. Before we continue, important reminder, this is educational information only, not medical advice. Prostate cancer detection requires individualized evaluation by a qualified urologist. Never delay or avoid medical care based on anything in this video. And if you want a free prostate cancer detection pathway guide, every tool explained with the questions to ask your urologist, drop the word "detect" in the comments right now. Now, the complete detection pathway, starting with what happens before any biopsy decision. Step 1. Understanding what PSA actually tells you about cancer risk. Before any detection tool is used, the first step is understanding what elevated PSA actually means and does not mean about cancer probability. PSA is prostate specific. It is not cancer specific. Elevated PSA has 3 possible sources: benign prostatic enlargement, BPH, prostate inflammation, prostatitis, and prostate cancer. In men with PSA between 4 and 10, the range where most elevated results fall, research shows cancer is present in approximately 25% of cases, meaning 75% of men in this range with elevated PSA do not have cancer. They have BPH or inflammation driving the number. This statistical reality is why detection sequence matters. Beginning with random biopsy in every elevated PSA case means subjecting 75 out of 100 men to an invasive procedure for a result that could have been predicted or excluded through less invasive tools first. His wife found a 2019 analysis in European Urology that reviewed detection outcomes in over 10,000 men. The authors concluded that PSA alone as the sole trigger for biopsy led to the highest rates of both missed significant cancers and unnecessary procedures of any detection approach studied. PSA is the starting signal, not the complete picture. What comes next determines everything. Question to ask your urologist. Given my PSA level and trend, what is my estimated probability of clinically significant cancer before we consider any biopsy? Step 2. Risk stratification tools before biopsy. His wife found 3 tools in her research that her husband's first urologist had not used. All 3 are designed to answer the same question before biopsy. How likely is clinically significant cancer specifically, not just any prostate abnormality? Tool 1. The Prostate Health Index, PHI. PHI combines total PSA, free PSA, and a third PSA variant called P2-PSA into a single score. Research published in the Journal of Urology found PHI was significantly more accurate than PSA alone in predicting clinically significant cancer, reducing unnecessary biopsies by up to 36% while missing fewer than 2% of significant findings. Tool 2, the 4K score test. The 4K score uses 4 kallikrein markers in the blood, including total PSA, free PSA, intact PSA, and human kallikrein 2, to calculate a personalized percentage probability of high-grade cancer. A landmark study in European urology followed over 6,000 men and found 4K score accurately predicted high-grade cancer with significantly greater precision than PSA alone. Tool 3. SelectMDx urine test. SelectMDx analyzes urine collected after prostate massage for 2 genetic markers, HOXC6 and DLX1, that are overexpressed in high-grade prostate cancer. A multicenter study published in European Urology found SelectMDx reduced unnecessary biopsies by 42% compared to PSA-based decision-making alone. None of these tools diagnoses cancer. Each one refines the probability estimate, giving the urologist and patient a more accurate picture of whether biopsy is genuinely warranted before proceeding. Question to ask your urologist. Before we discuss biopsy, have we considered PHI, 4K score, or a urine-based genetic marker test to better define my actual cancer probability? Step 3. MRI before biopsy. What the precision trial showed. This is the step that found what his wife's husband's first biopsy missed. Multiparametric MRI, MPMRI, of the prostate creates detailed imaging that identifies suspicious areas by their tissue characteristics. Not all prostate tissue looks the same on MRI. Areas with characteristics associated with high-grade cancer appear differently than benign tissue. The precision trial, published in the New England Journal of Medicine in 2018, compared 2 approaches in men with elevated PSA who had never been biopsied. Group A received standard 12-core random biopsy. Group B received MRI-first. If MRI showed a suspicious area, targeted biopsy of that area followed. If MRI was clear, biopsy was deferred. Results were significant. Group B detected 38% more clinically significant cancers than Group A. Group B performed 28% fewer biopsies overall. Men with clear MRI were spared unnecessary procedures. Group B detected 89% fewer insignificant low-grade findings, reducing overdetection of cancers unlikely to cause harm. The anterior zone of the prostate, where his wife's husband's Gleason 7 cancer was found, is consistently undersampled by standard 12-core random biopsy. It is a blind spot in the traditional approach. MRI identifies lesions in this zone that random cores simply do not reach. The American Urological Association updated its guidelines following precision to recommend MPMRI before biopsy as the preferred approach in most men with elevated PSA who have not previously been biopsied. Question to ask your urologist: should we do an MPMRI before biopsy to identify any suspicious areas and guide where we sample, rather than using random systematic cores? Step 4. Targeted biopsy, how it works and why location matters. If MRI identifies a suspicious area, what happens next is targeted biopsy. Understanding how this works helps men ask the right questions about their own procedure. Standard 12-core biopsy takes tissue samples from 12 predetermined locations distributed systematically across the prostate. It does not account for where suspicious tissue actually is. It is a map without a destination. Targeted biopsy combines MRI imaging with real-time ultrasound guidance to direct biopsy needles specifically to suspicious areas identified on MRI. There are 3 methods used clinically. Cognitive fusion. The urologist studies the MRI mentally and directs biopsy based on their spatial memory of where the lesion appeared. Accuracy depends heavily on the individual urologist's experience. Software fusion, MRI images are digitally overlaid onto real-time ultrasound during the procedure. The software guides needle placement to the exact coordinates of the MRI lesion. Research shows software fusion significantly outperforms cognitive fusion in lesion targeting accuracy. In-bore MRI biopsy. Biopsy is performed inside the MRI machine in real time. Highest targeting accuracy. Less widely available due to equipment and cost requirements. A meta-analysis published in European Urology Reviews, analyzing 48 studies, found that MRI-targeted biopsy detected 57% more high-grade cancers than standard biopsy, while detecting 45% fewer low-grade insignificant findings. Question to ask your urologist. If we proceed with targeted biopsy, which targeting method do you use? Software fusion or cognitive fusion? And what is your experience and detection rate with that specific approach? Step 5. After biopsy. Genetic testing for treatment decisions. Detection does not end with biopsy confirmation. For men whose biopsy finds cancer, the next detection challenge is determining how aggressive that cancer is and what it is likely to do over time. Gleason's score from biopsy provides one measure of aggressiveness, but two cancers with the same Gleason score can behave very differently. Genetic testing of biopsy tissue adds a critical layer of information. 3 tests have the most clinical evidence. Oncotype DX genomic prostate score analyzes 17 genes in biopsy tissue, produces a score predicting likelihood of cancer spread at 10 years. A study in European Urology found Oncotype DX changed treatment recommendations in 30% of men with low to intermediate risk cancer, either de-escalating from treatment to surveillance or escalating from surveillance to treatment based on genetic risk. Decipher Prostate analyzes 22 genes associated with cancer aggressiveness, particularly useful after surgery or radiation to assess recurrence risk. Research in the Journal of Clinical Oncology found Decipher score independently predicted metastasis risk beyond Gleason grade alone. Prolaris measures expression of 31 cell cycle progression genes, predicts 10-year cancer-specific mortality risk, helps distinguish men who need immediate treatment from those for whom active surveillance is appropriate. None of these tests is necessary for every man with a positive biopsy. They are most valuable in cases where standard pathology leaves treatment decisions unclear, particularly low to intermediate grade findings where the choice between active surveillance and treatment is not obvious from Gleason score alone. Question to ask your urologist. Given my biopsy result, is there a genomic test that could help us understand how aggressive this cancer is likely to be and whether active surveillance or treatment is more appropriate for my specific situation? His wife's husband went through every step of the complete pathway at the academic medical center. Step 1, PSA probability assessment. Estimated cancer probability 35%, based on PSA trend and free PSA ratio decline. Step 2, 4K score test. Result indicated elevated probability of high-grade disease. Biopsy warranted. Step 3, MP-MRI. Identified PI-RADS, 4 lesion in anterior zone, area standard biopsy had not adequately sampled. Step 4, software fusion targeted biopsy of MRI lesion plus standard systematic cores. Targeted cores found Gleason 7. Systematic cores negative, consistent with first biopsy result. Step 5, decipher genomic testing of positive cores. Intermediate genomic risk score. Treatment recommended over active surveillance. His wife said, every step answered a question the previous step could not. Together, they gave us a complete picture. His urologist said, this is exactly how detection should work. Not one test, a sequence of tools, each designed to answer a specific question. The first biopsy answered, are there cancer cells in the 12 locations we sampled? Answer, no. The complete pathway answered, is there clinically significant cancer in this prostate? Where is it? How aggressive is it? And what should we do about it? Answer, yes, anterior zone, intermediate risk, treatment recommended, different questions, different answers, different outcome. Imagine sitting across from your urologist after an elevated PSA result. You ask, before we discuss biopsy, have we used every available tool to understand my actual cancer probability and identify exactly where to look? Your urologist pauses, considers, explains the pathway. You leave that appointment not just with a biopsy scheduled, but with a sequence of steps designed to find what needs to be found and spare you from what does not need to be done. That is what his wife insisted on. That insistence found a Gleason 7 cancer that a standard negative biopsy had missed entirely. Detection is not one test. It is a sequence of questions, each answered by the right tool in the right order. You now know what that sequence looks like. Share this with one man over 60 with elevated PSA who has been told his biopsy was negative and has never heard about the detection tools that come before and after that single result. And drop detect in the comments for the free prostate cancer detection pathway guide. Every tool explained with the exact questions to bring to your next urologist appointment.